Pulmonary medicine. So we're going to look at some things that we do for patients who need pulmonary work. Let me come up a little bit on that. Whoa, not there. You can see all the cracks in my old house. Anyway, so we're going to talk about doing a pulmonary function test with our really ancient machine that we've got here. So we'll be doing that. And then we'll get into some other ways to evaluate a patient's breathing and respiration. And then we'll conclude with treatments for pulmonary issues. And Ray's again joined us here. He's my professional patient. So we're going to start with the pulmonary function testing. And like I say, the machine we've got is a really old machine. In fact, you can do much better. Let me make sure that this is. You can do much better nowadays. They have just a little attachment that looks somewhat like this that attaches to a computer, a laptop computer, and that's all you need. But the machine we've got is a really old Schiller Welch-Allyn machine. It kind of takes you back to the old days. If you remember the old cell phones where you had just the numeric pad, and if you wanted to spell something, you had to keep touching the numbers to get the correct letter, and some of you aren't even that old, but I am. And so this machine is that era. It hadn't been calibrated in probably 10 years. So, but it'll still give you the idea on what you need to do for a pulmonary function test. Okay, so let me show you the machine first, and I don't think I can do it. Whoops, no, I can't do it showing you the ceiling. So I have this thing upside down. So I'm going to pan over to here to the machine, not my belt. A little sensitive on this thing here. And I'm actually going to hold the machine up so you can see it a little bit better. So this is the Schiller machine. Let me lower this one down a bit here. Hang on just a second. So when we're putting information into this machine, again, you have to keep punching these buttons until you get the name and all that in correct. And then the two most important buttons on this thing are start and stop. So we start by hitting patient data, and we put in all the information that the machine requires us to put in. And it will require us to put in the age, the weight, the sex, the nationality of the patient. And that's important information, once again, because like the EKG machine, this has an algorithm that it will access to give us correct data that's normal for that particular individual. So we have to add all that information into the machine. And then once we get that information into the machine, then we're going to run 3 consecutive tests in a row, where we're going to have the patient take in a really big deep breath and blast it out as hard and as fast as they can, and then take a big breath back in. Now the one thing I don't have with me are nose clips, so Ray, can you breathe strictly through your mouth, or are you going to have to pinch your nose?
I can breathe through my mouth.
Okay, all right, because you have to have their nose occluded somehow or another. So it may affect the results somewhat, that's fine. We're just doing the demonstration for this anyway. So like I said, the most important buttons are start and stop buttons. So after I've entered the information, and I'm going to tell Ray to take a big breath in, and just as he gets ready to blast it out, I'm going to hit start. And he's going to blast out that air, and he's going to keep blowing, keep blowing, keep blowing, keep blowing, keep blowing, and I'm going to coach him on that. And then at the end, when he can't blow out anymore, he's going to take a big breath in. And then at the end of that big breath in, I'm going to hit the stop button. And that's one round. Then we're going to do that again. So I'm going to hit this button up here called FVC. And I'll hit that, and once again, he'll take a big breath in, blast it out. I'll hit start when he blasts it out. And then when he takes that big breath in afterwards, I'll hit stop. And we'll repeat it a third time. And then after that, I will hit print, and the results will print out for us. Okay? And I'll show you what sort of a normal one looks like. It's not totally normal, because it's mine. and I have breathing issues, but I'll show it first to this camera right here. That's what a normal spirometer should look like. It's a called a flow volume loop over here, and then it shows you my volumes over here, and then it gives a bunch of statistical data over here. So let me show it to this camera now. So I have, again, this right here, where am I? Right here. This graph right here is the flow volume loop. So it shows how much he inhaled and then how much he exhaled. So that gives me his total vital capacity on how much he can take in and how much he can blow out. Okay? So this is actually, this top line is the blowing out. The bottom curve down here is when he inhales back in. And that tells me how much total lung capacity he has. Okay? And this one over here, the flatter curve gives me his volumes and his the speed at which he can exhale the breath. So that's forced vital capacity. It's also, we have an FEV1 2575. You don't need to know about that. But basically, it's how fast he can exhale, because problems with that would indicate airway constriction or restriction or something like that. Okay, so once again, we have all of this data that's given to us in a series of 3 breaths. So I'm going to start by inputting some information into the machine. I'll start by turning it, start by turning it on. Then I'm going to go to patient data. And here's the screen that we're getting here. You can't see it because of the reflection off it there, but it's going to ask me for his name, a patient number, which we just make up something, his age, his gender, his height, his weight, and his race. So all of those things have to be entered into this machine. And once again, this is kind of an archaic machine. Nowadays they just come with a little computer attachment, but this one's kind of fun in that regard if you like antiques. So we're gonna put in Ray's name, and again, this is I should be familiar with this technology because it was during my age, but yeah, okay. Now I go to A. Okay, and then I'm going to go to Y. Did you ever have to do this, Ray? Mm-hmm. Did you? Mm-hmm. Oh, that's right. You're an old man now. Mm-hmm. So I'm going to hit enter. I entered his name. Now I'm going to put in just a number for a room number, and I'll enter that, or a patient number. And your age is 34. Is that correct?
35.
35. When did you have a birthday?
This week, actually.
Did you really? Mm-hmm. You didn't tell me. And what is your height?
5'6".
5'6". So you're 66 inches.
Yes.
Okay. Because this requires that we put it in inches. So he's 5'6", so that's 66 inches. And your pound? Your what?
130 pounds.
130. And your race?
Is it Asian or Indian? However it does it.
I think we have an A over there, so I'm going to cursor over using this cursor button to select Asian. Okay. Now we are ready to begin the test. So here is the scale that we're going to use. I'm going to put a mouthpiece on it. Single patient use single patient use mouthpiece. There we go. Okay, and it fits on. I'll do it to this camera first because I'm doing multiple cameras here. You can see there's 2 holes in a pin, and there's 2 little tubes in a pin. So line those things up. On this camera, there's 2 holes in a pin, and better back that up a little bit. And then you can see that there's 2 tubes and a pin. So you line that pin up. Until it snaps into place, and then you've got it in position, and they're going to blow in through this end. Now, the important thing about this, you will get a sensor error if the patient moves too much. If the sensor moves around when they're getting ready to take a breath, it's going to give us an error. So what I need to make sure that the patient does is that when he blows out initially, or when he takes in that real big deep breath initially, this needs to be really close to his mouth. So all he has to do is stick it in his mouth to blow out. Okay? Because it will give me an error and we'll have to repeat the test. Okay? So I have him sitting in a chair. I have his feet up flat on the ground. Now what I'm going to caution him about doing is, first of all, not doing anything through his nose. And I better move that camera over a little bit. Because you need, and I'm going to move back over. I don't know why this thing is so twitchy today. I'll back out a little bit more. So I have him sitting in a chair. His back is straight, and I want to make sure he keeps his back straight. I don't want him bending forward as he exhales on this, because that's going to create a little bit of an issue. It's going to give us inaccurate results. Now let's see if I can get the machine in with this other one. You got a good view on that one camera there, but I think that'll get it. I need a cameraman, don't I?
Yes.
Yeah, that's what I need. All right, so I'm going to instruct Ray to take in a real big deep breath, and then as soon as he's taken in as big a breath as he can, he's going to put that sensor in his mouth and blow out as hard as he can. And right as he puts that sensor in his mouth, I'm going to hit the start button here. And then he's going to blow all that air out as much as he can, and when he's done that, he's going to take in a big deep breath with the mouthpiece still in his mouth, and then after that I will hit stop. And we're going to do that 3 times. Okay? So are you ready, Ray?
Mm-hmm.
Okay, big breath in. In your mouth, blow, 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 blow. Keep blowing, keep blowing, keep blowing, keep blowing. Blow, 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 and inhale, big. Good job. Okay. Okay, we're going to do, that one didn't work out so well, so that was a good practice one. So we're going to do 3 more now, and hopefully you won't pass out in the meantime, right? Okay, big deep breath in. Put that in your mouth. Blow, 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 blow. Keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. Blow, 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 and inhale. Okay. All right. We're going to do another one. Give you a second so that the stars go away. Okay. Take a big breath in. Big breath in, and blow, 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 blow. Keep blowing, keep blowing, keep blowing. Blow, 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 and inhale. Okay, good deal. Whoops. I don't know why I printed that. Okay, it said that the movement of the thing was too much. So, okay. So here we go. You ready?
Mm-hmm.
All right. Blow, 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 blow. It still gave me an error. Okay.
Okay.
So you got to keep that thing still. It's just amazing how silly it is. All right.
Okay.
Big breath in. And blow, 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 blow. Okay. Here's what we're going to do.
I really barely moved.
I know. Here's what we're going to do now.
Uh-huh.
Is you're going to put that in your mouth for starters.
Okay.
Okay? Because sometimes that it just gets really sensitive that way. And I have another one of these cables. If this one continues to give us errors, we can try the other cable as well. So take in a real big deep breath. And blow. Blow, 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 blow. Keep blowing, keep blowing, keep blowing, keep blowing. Blow, 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 blow. And inhale. Okay. Now, I'm going to give you a break, and then we're going to get a fresh set, okay?
Okay.
Because I'm trying to make sure that we get good stuff here. So it's very critical, 2 things, that the offset be held really still, and that's what's considered the offset. And then the other thing is that that he not lean forward when he's trying to exhale. And the third thing is that you don't breathe through your nose. Okay. All right. Whenever you're ready. And blow, 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 blow.
Okay.
I don't know why. I don't know. It may be the cable. You know, we have to make sure it's really plugged in. Okay. All right. Blow, 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 blow. Okay, we're going to switch out that cable, see if that doesn't do any good. It keeps giving us an error. Ray is going to pass out cold.
Remove this?
Yeah. This cable won't work. That's interesting. It won't work on either of those ports, so we'll have to use this one. Wonder what machine we have in a closet somewhere that goes to. There we go. Okay. Let's see what we do.
Ready?
Yeah. Blow, 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 and inhale. Okay. Okay. All right. Let's do another. Blow, 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 blow. All right. You know what we're going to do? We're going to say that you've done 3 of those because you've done about 100 of them. So we're going to go ahead and print that out. Okay. So that's what it looked like. Now, you'll be happy to know that you have very good lungs because, assuming this machine was calibrated, which we know it hadn't been in 10 years, but all of your values are greater than 100% predicted. So like here's one that's 150% of your predicted, and that's your FEF 75, which is your forced expiratory flow at 2/3 of the way through your exhalation. So you're moving a lot of good air.
Okay, good.
You don't have any airway obstructions or anything like that. So this is what the printout looks like. And because his inhalation loops were so big, it had to print it out on a different page. That's what it looks like. So here's his volume and the speed with which he's getting that out of his lungs. So this is liters over seconds. So he's really doing about 3 liters per second. That's pretty good. And then here are his volumes. These are when he exhales, and these over here are when he inhales. So his maximum exhaling volume was about 8 liters per second, and his maximum inhalation was about 6 liters per second. So he's got good lungs. He's a runner. What do we know? Okay, so this is pretty much what we get when we print this out. All right, now there's another way to do this if you don't have a big fancy non-working machine like this. And it's called a peak flow meter. A lot of patients have peak flow meters, especially patients who have a history of asthma or something like that, because this thing will measure how quickly you can get a breath out of you, and if that's restricted, then the problem is usually that you have your airways are narrowed for some reason, so it's usually an asthmatic attack or something like that. Now, we do this to see how bad a patient is having an asthma attack, but if it's clear that they're in a whole lot of distress, don't have them do this. It's only going to make matters worse. So if they're in a lot of distress already, don't sit there and make them do a peak flow meter. Just assume they're in distress and give them the treatment for it, okay? But this is a peak flow meter. It's measured in liters per minute. It's a little disposable mouthpiece on it. But these are usually single patient use items. In other words, once the patient uses it, it's theirs to keep. Okay? So what I instruct Ray to do is either stand up straight or sit down with his feet flat on the floor. And it's going to be pretty much like the spirometer. He's going to take in a really, really big deep breath and then blast it out as hard as he can through there. And you don't need to keep blasting it out. It's just a really quick, as high as you can get it initially.
Okay.
Okay? Goodness me. All right. So he's moving, the little arrow right here is at 700 milliliters, or pardon me, 700 liters. Right there. So that's 700 liters per minute. That's really good.
Is it?
That's really good. So typically what I would do is I would have the patient do about 3 of these and then take the highest reading. I would make a note of that one. I can also move these little cursors up to there and say that's where he was. And then it comes with a little chart that will tell me, based on his height and his weight, what his predicted should be, so I can set this other one up to what his predicted would be. I don't have that little chart with me. You can download it. You can get it online. So I can measure his predicted and then what his actual was. So it's a little mini spirometer that you don't have to calibrate or put information into. And again, this would be his from now on. We also have, this isn't really used to measure anything, it's more of an exercise device. And if you've ever been in surgery, you've been given one of these to come home with, and you consider it a torture device because it makes you breathe deep. That's its whole purpose. It makes you breathe deep. Now, being the total respiratory nerd that I am, and I am, with COVID going around and all that, I bought one of these for all the neighbors because the average age in my neighborhood is 80. And I wanted all my neighbors, you know, they don't exercise as much as they should, but this is one of the key ways we keep from getting pneumonia, is to be able to take big breaths. Now, normally, several times a day, we take a sigh. You're not aware of it, but usually you take a sigh about 12 times an hour, where you take a bigger breath than normal. But as we age, we tend not to take as big a breaths as we should, and the lower parts of your lungs can actually collapse and not get air into them, and that sets it up for getting an infection in there. So we want to keep the lungs aerated well. After surgery, they hand patients these and say, do this. See how high you can make this little bellows go up. And the purpose for that is to just make sure, especially if you've had general anesthesia with gases, those tend to collapse the alveoli. So to reopen those up, we have patients do this. Okay? So it's really simple to instruct the patient on how to do. They're just going to put that in their mouth, breathe only through their mouth, not their nose, and they're going to suck gently on this to see how high they can get the bellows. And you want this little indicator over here. You can't see it against my blue shirt because it's blue too. But this little indicator you want to keep between the two arrows here so that you're not breathing in too fast. That's kind of the problem with this. You don't want to really suck in hard on it. You want to just nice, gently, and easy so that the air goes in deeper. Okay?
So it's inhaling.
It's inhaling. This one is an inhalation. Blow everything out first, yeah. Making me sick. So what'd you get, about 27?
You got about 27.3. Yeah.
Okay. All right. All right. So you would probably instruct the patient to do this maybe 30 times a day, do 5 or 6 breaths at a time, and then take a break, and then do it again. And you can keep that. That's your souvenir for the day.
Okay.
So on days when you can't go out jogging, you can just breathe deep.
Just breathe deep.
Yeah.
What are your favorites?
All right. Okay, so now that brings us, those are ways that we diagnose. So we have the pulmonary function that we can do. And once again, I just want to point out what a normal one, well, mine's not normal because I have very reduced lung capacity. But in fact, my values are nowhere near what my predicted should be based on my age and my weight. But then ever since I had my stroke, they haven't been that way. They haven't been good. So but here's what the flow volume loop looks like here. And that's what it should look like. And the changes in the shape of this and the changes in this graph tell the doctor what kind of issues you got going on. So that's why this is important data to have. And again, Ray's was quite a bit better. He's a show off. So this is pretty much his graph. And he had much better volumes. Much better volumes. And you can see his percent predicted right here shows that he was like 87% of predicted, 94% of predicted, 110% of predicted. So he's an overachiever. All right, so now let's talk about therapy aids that we have for helping a patient who may be in respiratory distress or have respiratory issues. Ugh. Trying to get one camera adjusted, so y'all just bear with me here a little bit. And what did I do with my remote? I'm going to pan out a little bit more. I'm going to come over here, and there's you should have already gotten the video on oxygen therapy and the various devices we have to deliver oxygen. So now we're going to talk about various devices we have to deliver medication to the patient. We're going to start with a metered dose inhaler. This is what a metered dose inhaler looks like. Well, actually, this is what the box to a metered dose inhaler looks like. Okay. These are also called MDIs. Essentially what we're dealing with is it's a gas-powered medication. There's a aerosol in here as well as the medication, and the patient delivers this normally to themselves, but on occasion we're going to have to give this to the patient as well. In any case, you're probably going to be responsible for instructing the patient on how to use it at home. Have you ever used an inhaler? Okay. So I'm trying to get where both cameras can see this here. So this is a metered dose inhaler, and the first thing I'm going to do is I'm going to take the medication out, and I'm going to look at it and make sure it's the medication that was ordered by the doctor. Check the expiration date and make sure that the medicine is good. Remember, anytime we give a medication to a patient, we always check it at least 3 times. We check it when we pull it off the shelf, we check it right before we give it to the patient, and then immediately after we give it to the patient. In the case of some medications, we check it after we get it off the shelf, after we've drawn it up, and right before we give it to the patient. So it all depends on what medication you're giving. Since we don't draw this one up, we want to make sure that we've given them the right one. Also, any respiratory medications that we give have a tendency to affect the heart rate and the nervous system somewhat. Now, most of the drugs that we give through metered dose inhalers and small volume nebulizers now are beta-2 selective sympathomimetics. That's a really fancy word for saying that they target the lungs and try to leave the heart alone. But they're still going to have some effect on the heart as well and cause the heart rate to race, maybe cause the person to become excitable, maybe they may feel cold. All of those things are side effects of the drug, and those are normal unless unless it really gets going super fast, and then you need to stop and call the physician and get him in there to evaluate the patient. Now, when you're giving this medication, the order may read, give 1 puff, or have the patient take 3 puffs 4 times a day, or 3 puffs PRN for shortness of breath. Okay, so if they order that the patient is to have 3 puffs, it is not like this. That's not how you give it. It's not shotgun style. It's 1 puff, give them about a minute, another puff, give them about a minute, then the 3rd puff. You don't just shoot one right after another in. Okay? Now, the way this works is that, and I'm going to instruct Ray in how to do this. So let me see if I can bring this over a little bit more here. Whoa! Don't look at that. All right, so I've checked the label. This is the medication, and we're going to say that the doctor has ordered him to take 2 puffs anytime he gets short of breath. And so these sometimes are called rescue inhalers. Although there are a bunch of different inhalers out now, they're even toying with an insulin inhaler now. But right now, we're talking about respiratory drugs. And there's different classes of respiratory drugs. Again, the rescue inhalers are beta-2 selective drugs, like albuterol, Xopenex, Ventolin, Provenil, which are all albuterol types of drugs. And then we have other drugs, mast cell inhibitors that prevent inflammation or the allergic response kind of thing. So different kinds of drugs, and they sometimes come in combination with each other. But albuterol or levoalbuterol, which is the Xopenex, are the ones that we normally see in these inhalers. You can sometimes see Atrovent, which is albuterol, it's called a combovent. It's albuterol and Atrovent. So it not only promotes vasodilation, which is what albuterol does, but it also prevents bronchoconstriction. So 3 ways that we control the airway is we promote bronchodilation, we inhibit bronchoconstriction, and we decrease the inflammatory response. So in asthma patients, chronic bronchitis patients, that sort of thing is when we use this. Now here's how I'm going to instruct Ray to do this. He's going to blow everything out and then put this in his mouth, kind of like we started with the spirometer. So he's going to blow everything out, put this in his mouth, and after he starts inhaling, he's going to push the button and keep inhaling. Just push it once. It's going to deliver that metered dose, one-time dose. He's going to keep inhaling, and then he's going to take this out of his mouth, and he's going to rest for a minute, hold his breath for just a second or two, and then wait a little bit. He's going to take another breath in, and as he's taking that breath in, he pushes the trigger again. So basically what it looks like, see if I can get in the view of both cameras here. So essentially what it looks like is, and I'm just going to put this beside me here, that's one breath. Okay? So this just has the propellant, no drug, so you're not going to get high or anything on that. So give it a shot. And the reason we want him to be breathing in when he takes that breath is it entrains that medication way down deep into the airways. Otherwise, it's just going to hit the roof of his mouth and wash out, and he's not going to get much benefit from the drug. So ideally, the bigger, when he's inhaling, the medicine's going to go much deeper into his lungs. And that's it. Now, if a patient is in a whole lot of distress, and this is their rescue inhaler, I've seen them do this, where they go like that. They're not getting much medication. They could take an extra dose. It's not going to hurt them. Okay? But you try and want to stick to the dose that they're given. Metered dose inhalers work okay if you can't get to a nebulizer. The nebulizers, to me, are the most effective because it's given over a longer period of time. It adds moisture, and it gets the medication so much deeper. And the interesting thing about a small volume nebulizer that I'm going to show you, or a handheld neb, is that you can give it with oxygen. If you think the patient needs oxygen in addition to the medication, you just plug it into your oxygen, the nipple on your oxygen regulator, run it up at about 5 liters per minute until it's fizzing really well, and then have the patient breathe it that way. So you can do both things, giving oxygen and the medication. But for most patients, they're going to have be prescribed a home nebulizer like one like you see here. So again, I have a box of albuterol here, and this is real albuterol, so I'm not going to have Ray do this. I've dummy loaded one with saline. And so I check the expiration date on here. I'm not going to read you the prescription label. But it has an expiration date on it. This one is, actually this is just barely no good. It's July of 2020. Okay? Been sitting in a closet for a couple of years, I'm surprised. But they come in these foil pouches. These little things come in foil pouches. That's to protect them from light. If you don't protect them from light, they become a nice little coffee colored. And when you see that they're coffee colored, you can't use them anymore. Now, what's important about these things is that they all look alike. All these little nebulizer things. One camera than the other here. So all these nebulizer things look alike. They come in similar containers, and the only way I can tell this is albuterol is that it has a big A up here, and it says albuterol on the side, but I need to examine that really close. So this is albuterol, has a little A up here on the tab, and it says albuterol on the side of the medication. But you need to look closely, because this and chromalum sodium and a whole mess of others come in this exact same kind of packaging. And you cannot tell them apart, so you need to look really close. So in order to use this, we're just going to use one. So I've peeled it off, and then I'll snap the cap off and I'll administer that. We'll get our setup going here. I am actually going to move to the other side over here, I think. We don't have to play to two different cameras. I'll just go over here like this. Back you up slightly. Okay, so this is a small volume nebulizer. Ever done one of these before? See, this is your birthday party present from me.
Yes.
We do all fun new stuff. So it has a T-bar. T-bar looking thing there. And I'm going to put the mouthpiece in one side, and then it has a little bit of dead space tubing that I put on the back of that. That keeps all the medication from just pouring out the back end. Kind of concentrates some of it here so that the patient can breathe it in. And then my nebulizer container, that fits right on there. And then my tubing, which again, this tubing can either go on an oxygen cylinder or it can go on a home powered nebulizer, okay? Because the fitting's the same. Okay, I'm going to plug this into my machine. My machine over here. So here's our machine, and it plugs in right here. Now, you should check this filter out every so often. This one is hideous. It's filthy as it can be, but nobody really uses this machine anymore. So that just provides better airflow through the machine when it gets clogged up. It's not that he's going to get any dirty air. It's just probably it'll burn out the machine quicker. Okay. So I've got that in there, and now I'm going to put the medication in this chamber right here. And again, I've loaded this one up with just plain water, so it's not going to give him a buzz. Sorry. So I unscrew the top and I put the medication in there, and then screw the top back on. And what I'm going to instruct him to do is just breathe in and out through his mouth. And I'll turn the machine on. It's going to be a little bit loud. And you'll see that it's starting to fog there at the end. And I would have him do this till the medication runs out. Now, if he's doing this in the office, I'm going to check his pulse to make sure, to see what it is baseline before we get really started. And then I'm going to continue to check it after the treatment's done. To make sure that he didn't get too much of a heart rate increase. because maybe this is the first time to get a treatment, he's doing it in the office for the first time, and maybe he doesn't tolerate that medication well. Maybe we need to go to, like I say, leave albuterol instead of albuterol. Just a little bit different in its configuration, or we can use some other type of bronchodilator. Okay, so once again, he would do this until it's completed. I would keep monitoring his heart rate to make sure that it was working. I would also listen to his breath sounds before and after. Let me go get my stethoscope and we'll go ahead and do breath sounds assessment. And I'll try and post, if I don't get a chance to post, I want you to go online and I want you to find a video on breath sounds, and I want you to listen to the various breath sounds, particularly wheezing and stridor and crackles. So I want you to listen to wheezing, stridor, and crackles. In the case of asthmatic patients, wheezing is what we're likely to hear. If somebody has an upper airway obstruction, stridor is what we're likely to hear. And if somebody has pulmonary edema, their lungs are filling with fluid, then we're going to hear crackles, which is a very moist sound. Okay, so I'm going to get my stethoscope. You can go ahead and take your shirt off. I'll be right back. Go kit that I always have by the door, along with my defibrillator and all that. I'm just going to use the stethoscope here. Okay, I'm going to lower this camera down a bit. Actually, you can probably sit up on the table now. There's space for you. A little bit higher. So if I'm listening to breath sounds, once again, remember that with your stethoscope, the earpieces have to angle forward because your ear canals angle forward. So this is going to go in my ears like that. And then what I'm doing when I listen to breath sounds is I'm comparing one side to the other. So I don't just go down one side and then the other side. I go one side, then a crossover, down, crossover, and do that in several places. And the one thing I want to point out is that his lungs actually come up here behind his clavicles. So they go up really, really high. And then when he's taking a big, deep breath, his diaphragm is down here. When he completely exhales, his diaphragm is up here. So the chest cavity is a very dynamic cavity. It depends on whether they're inhaling or exhaling that will determine where exactly we'll listen to their lungs. So we have the patient breathe in and out gently while we listen, and we have them breathe in and out through their mouth because if they breathe in and out through their nose, that can transmit some sounds. So I start up here, and I just have him take a breath, and then I cross over, and then I move down, and over, and then over to the side, and then over to the side, and then I would repeat this on the back. I would listen one side, the other side, so, and I think in your book it has you listen to 8 places on the front of the chest. That's a little extreme. I don't think we need to do that. So I'm just going here, 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 and over here. Okay? And then doing the same on the back side as well. So that way we get a really good idea. And again, if I'm hearing stridor, stridor is an inspiratory sound. It comes from an upper airway obstruction. So if I'm hearing a lot of noise, if I'm hearing when I listen to his chest here, I want to put my stethoscope on his throat. And if it's really, really loud there, then that tells me he's got some kind of problem with his throat. It's being transmitted down into his lungs but the problem is more likely in his throat. More likely what I'm going to hear in the chest is wheezes, and with wheezes, when a patient exhales, that's when you're most likely going to hear wheezes. And we have different phases of wheezes. If it's an end expiratory wheeze, in other words, at the very end of his exhalation, when air is moving the slowest, if I hear a little squeak or something, that's what we call an end expiratory wheeze, a little. And that indicates he has a mild airway restriction in there due to probably an asthma thing. As it gets worse, I start hearing biphasic wheezing, or I hear a prolonged expiratory wheeze first, so it'd be more like a that's worse than the okay, so it's getting worse. And then even worse is if I hear a biphasic, both inspiratory and expiratory wheeze. That's even worse. And the worst case scenario is when you can't hear any breath sounds at all. If they're going through the motions of breathing, but they're not moving enough air to produce any sounds, they're in real serious shape. You need to pull out your bag valve mask, as we talked about in that other video, and you need to start breathing for them, because they're not doing well enough on their own. Okay? When you're delivering an albuterol treatment, or any other medication for that matter, the goal is to decrease that wheezing. So maybe wheezing really bad when we first listen, when we're just starting the treatment, and then that may settle down as the treatment progresses, and that tells us the medication's working. If it's not, we may have to add steroids or something like that. If that doesn't work, they really need to be in the hospital. Okay? Now, if I have a patient, you want your shirt back? Sure. If I have a patient who is a mouth breather, they don't breathe through their nose, so consequently, or let me put it this way, they're a nose breather, don't breathe through their mouth, then this isn't going to work real well. So what I can do is put an aerosol mask on there instead. This is an aerosol mask, and it's designed to, when I turn it on, medication fills the mask and they can breathe it in that way. Now, I don't like this as much as using the mouthpiece, because a lot of this medication is going to rain out in the upper airway and the patient's not going to get any benefit from it. So the mouthpiece is always better because it's more of a straight shot. But just keep in mind that this is an option for patients who want to breathe through their nose and not through their mouth. Okay? I think that's it. We've done the spirometer, we've done peak flow meter, we've done incentive spirometer. We've done albuterol by meter dose inhaler, we've done albuterol by small volume nebulizer, and I think that's probably going to conclude this session then, so I'll turn off the recording now and we'll reset for a little another thing.